All right, I think I'm done now. So good evening, everybody.
Good evening.
All right.
Good evening.
So,
Evening.
all right. So you're gonna start another session, and as we mourn as a nation, can we also, in our own small way, have a minute silence for the souls of our great men who passed away? May the good Lord, who knows and understands all things, keep them safe in the arms of their Maker until the end of time. Amen.
Amen.
All right. So as we move on, we said that we're looking at some conditions and diseases that affect the genitals. And for that matter, specifically, we're looking at the penis. So in general, you have what we call the genital ulcer diseases. Diseases that actually affect the genitals, and in generality, the genitals will include the penis, the scrotum, even the perineal area, and sometimes even the anus. All right, but we will still restrict ourselves as much as possible to those that affect the penis. And as we move along, we're taking the structures and the organs of the male reproductive system one after the other and considering the conditions that affect them individually. So we continue with the one on the penis. Right. So genital ulcer diseases are open ulcers, are open sores or ulcer. I hope you know the difference between sores and ulcers. They are basically the same, except that ulcers appear to be larger and deeper and often take a long time to heal. Sores can be any small scratch anywhere with an opening can be a sore. All right. So anything of that sort on the genital area, of course, including the penis, is a genital ulcer disease, GUD. If you want to be specific with the penis, you can say penile ulcer disease, and that will be PUD. All right. But the general term here will be the genital ulcer disease. There are many causes. There are many situations where an ulcer, and for that matter, a sore can develop in the genital area. But the most common ones are sexually transmitted infections, especially with respect to the penis. When we're dealing with sexuality, we are looking at sexual intercourse. And with sexual intercourse for the male organ, it is the penis that does the penetration. So if there's going to be any sexually transmitted disease, we expect that it should affect the penis. So there are a lot of sexually transmitted infections. But here too, we are restricting ourselves to those ones that will affect the penis. I hope you are getting me. Right. There are a lot of sexually transmitted infections. Some of them have nothing to do with the penis, even though the penis may be the conduit for which the sexual activity will have taken place. But the repercussions or its effect may not directly be on the penis. So as far as this discussion is concerned, we are looking at sexually transmitted infections that will cause genital ulcers. All right. So we're going to look at 4 of them. And today we're going to look at one. The 4 are syphilis. The other day, I remember my lady wanted to ask to deal with some aspect of it. And I said that we should wait because we're going to do the discussion. Sometimes the discussion will even answer the problems that you have so that you don't even need to ask again. All right, so that's why I requested that you should hold on with the question. I'm sure after this discussion, the answers will be very obvious. So we're going to look at syphilis, which is called by Treponema pallidum. We're going to look at chancroid, which is Haemophilus caused by Haemophilus ducreyi. Chancroid and syphilis all cause penile ulcers. And by the time you finish the discussion, you'll be able to appreciate the difference between the two. The difference here, of course, is the fact that the causative agents are different, even though they are all bacteria. But this bacteria is Treponema, the other one is Haemophilus. And technically, they belong to different groups, okay? But they have a lot of similarities. And as a scientist, you should be able to immediately differentiate even the physical, the source. You should be able to differentiate a sore, which is caused by syphilis, and a sore caused as a result of chancroid. All right. So we also have genital herpes, which is caused by herpes simplex virus type 1 and virus type 2. So we have the HSV1 and HSV2. I mean, the 1 and 2 are the serotypes of the herpes simplex virus. And as we get to that area, you see that the 2 is technically for those who are engaged in oral sex. And 1 is, of course, the one that all of us know, that the vaginal sex. All right. Then we also have lymphogranuloma venereum, LGV, also caused by Chlamydia trachomatis. And here too, you're looking at specific serovars or serotypes or genotypes. And these are the L1, L2, or L3. They can cause the LGVs. All right, so by the time you finish, you have gotten a very idea about the kind of sores that may appear on the penis, their looks, and what to suspect, and what tests to do to be able to confirm your suspicion or your preliminary diagnosis. So today we're going to look at syphilis. Syphilis. It's causing a lot of problems, especially when you listen to the herbalists and when they are promoting their drugs and the kind of things that they say about it. So as scientists, and even when it comes to diagnosis, there are a lot of diagnostic approaches which we are using as lab scientists, which are very, very misleading. I hope some of you are on the GAMS platform, which has been designated as clinical, is it clinical voice or clinical forum? Do you have any of you on that platform? GAMS clinical forum or something? Do you have anyone here who is on that platform? GAMS clinical voice. GAMS clinical voice. I believe all of you are GAMS members, or most of you, or you don't belong to the professional body.
Yes, sir.
You all belong.
Yeah. I'm on it. I'm on it.
You're on the GAMS clinical voice platform.
Yes, sir.
No,
Okay.
the regional.
The original.
No, this is the
Yes.
national one, the one that we created.
Okay. So I'm saying that, are you all, those of us in this program, are you all members of GAMS? If you are not, please do. Those of you, especially those who are in private practice, they hardly belong to the professional body. Please do make sure you are part of it, because that's also another avenue that you can also learn something. You can't learn everything from school. There's no way you can learn, even if you spend 10 years in school, you still cannot finish learning. Right? So when you come out from school, you should have certain avenues of also learning. You can learn from your peers, you can learn from your seniors, you can learn from other professional platforms. All right, and GAMS is the professional body. And I encourage all of you, if you are already not a member, a registered member, please do that one for me. All right. Do it, and I'm sure you'll benefit from it. So the GAMS, they have the GAMS clinical voice platform, and the syphilis testing this thing featured strongly on that platform yesterday and today. I've intentionally not contributed. I was just following what was happening on that platform. So you also realize that by the time you finish this course, you see that probably you're also doing something wrong in your facility about syphilis diagnosis. All right. And my prayer is that once we finish, then you should be able to correct the errors that you may be making. All right. Okay. So syphilis. Of course, syphilis is caused by Treponema pallidum. All right. All right. As we move along, you realize that there are even subspecies. Just as, let's say, you have the chlamydia, for example, so that we say we could have serovars or serotypes, the L1, L2, L3. So with the Treponema pallidum, we also have subspecies, and very soon we will get to know all of them. So, but in brief, we say that it's called by Treponema pallidum. So it is a bacteria, obligate microaerophilic spirochete. So look at the fact that it's a spirochete. So it is that kind of winding corkscrew type of bacteria. All right. So these things are very, very important because as you move along, you realize why certain things cannot be done in the labs. Okay. Right. So T. pallidum is an obligate microaerophilic spirochete. What it means is that once, if you want to grow it, it doesn't need too much of oxygen. Okay, right. So what's the difference between macroaerophilic organism and then capnophilic organism? I hope a lot of you are doing microbiology. You are doing cultures in your labs. What's the difference between microaerophilic and capnophilic organisms? If you're able to tell me, I'll put down your name. You have some 10 marks in store already. If you're able to tell me, I will let it be recorded as a bonus mark for you. And that will be part of your assessment. Capnophilic and then microaerophilic organisms. Anyone with an idea? Okay, right. So you see that if, for example, in your labs, if you want to culture certain organisms like Neisseria, all right, and then you plate on chocolate agar. You see that normally you put in a CO2 jar. Do you have any of you here who has no idea about cultures? I'm sure even if you're not doing microbiology in your facility, in school, and especially if you did some rotation or you did your service or internship, you necessarily have passed through a microbiology lab. And you understand that in culturing certain organisms, the plates, especially those either seeded on chocolate agar or brown agar, will be placed in a CO2 jar. Okay, the CO2 jar, what it means is that there's a jar, and then having put in your plates, you light a candle and then just leave it and then close it. Sometimes you ask students what it is, and they tell you that it is about anaerobic. It is not anaerobic. It is not anaerobic. There are certain organisms that require an increased CO2 an increased CO2. And you see that in the normal environment, in air, because if you have an incubator, then you put anything in there, the air is the same thing as the air outside. After all, the air outside, some of them have been captured within the incubator. All right, so the incubator inside there is air. And so if you are dealing with organisms that are aerobic, all that you need is just put it in the CO2, sorry, in the incubator, and that is it. If the organism require higher, and by the way, what is the concentration of CO2 in air, the normal air that is around us? You can tell me. I'm sure this one, even GHS people do it. They know the composition of air, and they will tell you the composition of oxygen in air, composition of nitrogen, the percentage of nitrogen in air, the percentage of CO2 in air. This is what I'm talking about. The air around us, what is the percentage of CO2? Yes, I think somebody has put something there. I thought somebody put something in the chat. Okay, so somebody answered microaerophoric require oxygen, but at lower levels, as anaerobic does not require oxygen for growth. Then he said, yeah, that's okay, but you see that it appears you are mixing microaerophoric and then anaerobic. Okay. All right. So yes, let's go. Let's get this thing right. So the amount of or percentage of CO2 in air, the normal air around us, nobody can tell me. That is bad.
Papa,
Yes, sir.
is it 0.042%? 0.042%.
Okay. All right. So it's about 0.03 to about 0.3%. That's 0.03. Okay. So you see that's very, very small. Meanwhile, certain organisms require about 5% of CO2. So it means that if you just put it in your incubator, that organism will not grow. All right. It requires, okay, so 0.04, that's okay. 0.03, 0.04 is correct. And this is coming from Josephine, that's correct. So that's how low it is, 0.03, 0.04. That's the concentration or the percentage of CO2 in air. So if you open your incubator and put any plate in there, all the CO2 that's available to the organism is 0.03 or 0.04. Meanwhile, that organism requires a percentage of about 5%. So how will it grow? It can grow. And all you do is that there's no bacteria, you report no bacterial growth. Meanwhile, you didn't provide the conditions that the organism so requires. So what you do is that if you know that this organism is requiring 5%, what you do is that you just create that environment where CO2 will be increased. And that's very simple. You have a jar, you put your plate in there, you put a candle, a burning candle, you put it there and close it. You know that as you close it, the candle will be burning and will be consuming oxygen because oxygen supports burning. Is that all right? So the oxygen within the can will be used for the burning. At a point, the oxygen will get to a point where it cannot support burning. But that doesn't mean that the oxygen has been exhausted. That's the difference between microaerophoric and then the anaerobic. Anaerobic doesn't need the slightest amount of oxygen. It doesn't need oxygen at all. If you put in the candle in there, what it does is that at a certain point, the oxygen available will not be enough to support burning. But that doesn't mean that the environment has become anaerobic. That is the difficulty in people understanding that thing. Anytime you ask students in the candle jar, what is there, they will always tell you it's anaerobic. It's not anaerobic. Oxygen in there has been used, not completely, but has been used to support the burning. At a point, the amount required to support the burning will not be adequate. So the candle will go off. Meanwhile, during the burning, the output is CO2. So you see that the oxygen concentration is going to go down because it's being used in the burning, and CO2 is also going to go up because burning itself is also creating a CO2. So by the time the kernel goes off, CO2 will have moved from the 0.04 to about 5%, which is enough for the required environment for the oxygen, sorry, for the organism. Meanwhile, the CO2, so the oxygen will have also reduced significantly. All right, so you are creating a macro aerophilic environment, also creating a capnophilic environment. Capnophilic is just the lab for increased concentration of CO2. So organisms that require higher CO2, they are capnophiles or capnophilic. So you must know those organisms, and almost all the time, almost invariably, all capnophilic organisms are also macroaerophilic. What it means is that those who require more CO2, they also require less of oxygen. So, hello, is somebody asking a question?
So when is one come?
So that's how come it is possible to create that environment in the lab.
This how long does it take before it's clear from the system?
Gladys, can you meet?
This one's the only
Gladys,
medication.
Hello.
can you
Yeah,
meet?
grandpa.
All right, so that's just that. So macroaerophilic, so if you are to grow the tea palladium, for example, probably you also require that, invariably, you can put it in a CO2 jar. All right, the CO2 jar, by that philosophy of, by that principle, will create macroaerophilic environment. At the same time, will give you an increased CO2, which is capnophilic. All right, so that's just by the way. I also want you to take a note about the dimensions of the saponema. All right, so because it's a spiral case, it's winding, all right, and then this is the length from 5 to 20 microns in length. Look at the diameter. The diameter is 0.1 to 0.4. So it means that you can get it around 0.1, 0.2, 0.3. But who can tell me the resolving power for an ordinary microscope? What's the resolving power? So to understand some of this, that's why I always tell you that, you see, the basic sciences that you do, if you just do them and throw them away, it becomes difficult for you to explain a lot of the principles that guide our practice. Okay, so just move on. So the resolving power of the microscope is 0.2. So since you are going to get some organisms which are 0.1, what it means is that this organisms is what? The submicroscopic, that is below. When you say sub, it means below. It is below the level that a microscope can see. So it means that an ordinary microscope cannot be able to observe or detect the T palladium. This is very, very important. So I will not just tell you that T palladium normally normal microscopy will not be able to detect it. But you must understand why you cannot detect it. Because the minimum level, when I say resolving power, that's the minimum level that an object can be seen as such. All right. So if the length, as for the length, there's no problem. But we're looking at the length and the diameter. The diameter is in the range of 0.1. What it means is that it is so slender. It is so slender that it becomes submicroscopic. It means that it is below the capacity of a microscope to observe it. That's as simple as that. And as we move along, I'll give you more information about why the T palladium, for example, cannot be observed simply in the lab. Okay. And we also, the organism exhibits corkscrew-like motility. So if you are going to use any means to observe the organism, your power or your ability to see it will be lied in the fact that it is motile. Okay, so if you, once you know that it is motile, it's a motile organism, if you make a preparation and you are observing or looking for the treponema, you are looking for something which is motile. All right. So these are the things that will guide you as you move along. So let's look at the real causative agent of the syphilis. Remember I said that the T palladium has subspecies. Okay, just as you could have serotypes or genotypes of a lot of organisms. So the T palladium also have subspecies. So you have T palladium, subspecies palladium, which causes the syphilis. So you should appreciate the fact that T palladium has subspecies. So that will explain to you why, even when we say that as you move along, you explain that once you have the organism infecting you, it can develop, of course, can develop antibodies. But that antibodies cannot be specific. Even the ones that we say that is specific, the antibodies, as you move along, as I've said, you are going to know that the infection will cause the production of two key antibodies. One is specific and one is non-specific. I'm telling you here that even though that we say it is specific, it will not be specific for syphilis, because it is going to be specific for T palladium. But you have T palladium, palladium, T palladium pertini, T palladium endemicum, and T palladium caryatium. So even though that we say it is specific, it will only be specific for T palladium, and to not be specific for T palladium subspecies palladium. I hope you are getting me. These are the fundamentals. If you get it correct, as you move along, things becomes even easier for you. Remember, syphilis per se, we could have just mentioned it that, we are talking about genital ulcer disease. Then you talk about syphilis, or you mention syphilis as one of them. Then we move away. But now we are treating syphilis as a cause by itself. Okay, because I've done a course on treponins, which will involve this one. Okay, I've done a complete course on that for people. So what I'm saying here is that because of the confusions and then the misdiagnosis that goes on in most laboratories, I'm just trying to expand this aspect as part of your program, so that it's like you are going to kill two birds with one stone, because you should also have paid for syphilis course on its own. So take note on some of these things and learn appropriately. I'm saying that the T. pallidum itself, even though we say that syphilis is caused by T. pallidum, but it's caused by a subspecies of T. pallidum, which is T. pallidum pallidum. All right. You can also have T. pallidum pertinue, causes yours. A lot of you may not know now because yours is virtually almost, you can hardly see them these days. All right, but it used to be a condition that was affecting a lot of children in our country. We also have the subspecies endemicum causing endemic syphilis, which is also called BGL. And then T. pallidum subspecies carried to causes under the condition called PITA. But we restrict ourselves to T. pallidum subspecies pallidum. And as we move along, once we say T. pallidum, we may not add the subspecies pallidum because you know that we are talking about syphilis, and then we leave it from there. But I want you to know that if you just say T. pallidum, we also have subspecies that cause other conditions. Okay, all right. So let's look at routes or modes of transmission. The major mode of transmission for syphilis is sexual transmission. So sexual transmission, that's sexual intercourse, of course, you know. That's why it's a sexually transmitted infection. So that's the major or primary route of transmission. All right. And especially once you do so without the use of a condom with a partner who has a syphilis, then you are likely to contract it. Remember, I said that once you put on condom correctly and even consistently, it doesn't rule out an infection because it could rupture, anything could happen. All right, so take note of that. But at least it is a means of minimizing risk of infection to the barest minimum. All right. So, and then the sexual activity here also is vaginal, anal, or oral. So you can have vaginal sex, you can have anal sex, you can have oral sex. That's why somebody can have syphilis. You may not see the lesions, and for that matter, the sore on the penis or the vaginal area. If the person was engaged in oral sex, of course, you have the ulcer that you're going to talk about. You have it on the mouth. So once you have a typical syphilis sore on the mouth, straight away it tells you that the person was engaged in oral sex. Similarly, if you have it around the anus, the perineum, then it also tells you that the person have been engaged in anal sex. These are simple, basic scientific information that should guide, especially the clinicians. All right. So somebody will come in, the doctor may suspect syphilis, and then you look at the penis, there's nothing there. But probably the doctor may have done a better physical examination, including looking at the anal area or looking at the mouth. So if you think that syphilis is just some sore on the penis and just leave it like that, you may be making a mistake. But of course, with respect to this course, you will still restrict ourselves to the penis, okay? But I just want you to get a broader knowledge that when you're dealing with syphilis, it's not about the penis alone. It could include the anus, it could include the mouth area, and where the sore is an indicator of the source of infection or where the infection actually took place. Okay, right. So that's about it. Then there's also mother to child transmission, and that's called vertical transmission. I'm sure you know vertical transmission. Normally, if you have an infection and you give it to another person, I mean, you call it horizontal transmission. Okay, you know what is horizontal, as on the same line. So we are all alive, and then I have you become the source of transmission of an infection to another person. It's a horizontal transmission. However, if a mother is going to give birth to a child, remember there are two different generations. The mother is going to give birth to a child and that's another generation. And so it's going to be like from up coming down. I hope you get that point. So that's what we call vertical transmission. Vertical means something which is straight coming up and coming down. So from a mother to child, it's called vertical transmission. So I put this one there for you to guide you anytime that anybody is talking about vertical transmission. It's the same thing as mother to child transmission. Okay. And remember that it's not all infections that can be transmitted via vertical transmission. It's not every disease. But there are certain common diseases that can be, if the mother has it and the mother is pregnant, it can be transmitted through the placenta to the fetus or the unborn baby. And all those conditions are said to be vertical transmission. And syphilis is one of them. So that is why pregnant women are screened for syphilis. You see, because we want to minimize the mother to child transmission route, so that if the mother has it, straight away the mother will have to be what do you call it, treated as much as possible to prevent the mother to child transmission. Because if the mother is not treated, the risk or the likelihood of transmission to the child is very, very high. And once that happens, the child will be born with syphilis. And that's anytime you also have a baby born with an infection from the mother, it's congenital. So that will also lead to congenital syphilis. I'm mentioning some of these things. It is not within the context of the course that we are doing, but I'm bringing all this in up so that it also will help you to some extent once you are dealing with syphilis. Otherwise, I will have mentioned syphilis and we move on. But I want you to appreciate all these aspects, and it becomes bonus for you for going through this course. So that is that. So we don't screen mothers for syphilis for the sake of it. All right, we screen mothers because syphilis can be transmitted vertically or from mother to child. And the essence of the mother screening is to try to minimize the mother to child transmission route. Let's also look at some other routes of transmission. So we talk about the major one, the sexually transmitted. We talk about the vertical transmission, mother to child. There are other routes. Breastfeeding. Breastfeeding. You want to ask a question?
Yes, please.
Is somebody asking a question?
Yes, please.
Okay, come on.
Please, what of syphilis with non-active, non-sexually active?
Can you start again, please?
Okay, I'm asking of syphilis within non-sexually active patients. There are some patients who come, you ask them and they say they are not sexually active, but they have recurrent syphilis. So what's the cause of that also?
Okay, by the time we end the program, you'll know there is a lot of the diagnosis that we are making that they have recurrent syphilis, unless they have clinical manifestation, either historic history or something. A lot of the time, the tests that we are doing in our labs of syphilis, they are misleading, and you understand why as we move along. Okay, a lot people are being subjected to treatment for syphilis for no reason. Okay, so by the time you finish this submission, the answer will come to you. Okay, do you get me? Hello? Who asked the question, please?
Yes, please. I get it, please.
Okay, so I want a situation where by the time you finish, the answer, you yourself will have answered the question.
Okay.
So I'm saying breastfeeding per se will not give you, or syphilis will not be transmitted through the breastfeeding per se, but indirectly, if the mother has some sores or some cracks or some open wound somewhere around the breast, either one breast or both breasts, then that could be the source of the transmission. So take note. the breastfeeding per se for with an intact breast or intact nipple will not cause transmission of syphilis. But you see, the mothers, sometimes some of them, they will say that, oh, they have some cracks. They themselves can tell you that there's some sores on the nipple. But that one, they even encourage the breastfeeding because they think that while the baby sucks, then the wound will go away. Okay, so they will encourage that. If that mother is has syphilis, which probably has not been treated and they don't know, then that mother has potentially could transmit syphilis to the breastfeeding baby. I hope that point is clear. Are you getting me?
Yes, Grandpa.
I want a feedback because
Yes.
I've said over and over again that I want a situation where after this course, even if you don't read, a lot of things will have been very clear to you. All right.
Sure.
So then either direct contact. Syphilis can also be transmitted through direct contact with an infected sore on the body, such as through kissing, if the kissing partner has a sore in the mouth or on the lips, just as we were talking about the breastfeeding. If you are kissing, so once we say that it's sexually transmitted, if the argument is that it's always sexually transmitted and that is it, then you could get it wrong, because if the partner has syphilis and probably doesn't know, and he has some sore on the mouth, and you do a kissing, you could get syphilis straight away. Okay, so don't get the impression that it's always sexually transmitted. Oh, I didn't have sex with the person, and therefore I could not have gotten it. But if you have engaged yourself in any contact, a direct contact with this person, and the person has it, and there is some open sore, and you can easily get it. And as we move on, you see that there's a certain stage where there could be some rashes on the individual. So you may not have had sex with that individual, but any contact, direct contact with that individual, you could also have it. Okay, so these they could be rare, but they cannot be ruled out. And these are the things I want you to know. And of course, you also have occupational exposure. And as health workers, laboratory personnel, you stand the risk of occupational exposure if they come into contact with infected fluids or tissue or through needle sticking. I hope you understand, you know needle stick injuries.
Yes, please.
Yes, you know. So you may not have had sex with that person, with anybody, but if the sample you are dealing with, especially if it's a fluid, then you can, if you don't wear gloves and stuff like that, and then you also have some cut on your hand or something, then you could also get it, even though you haven't engaged in any sexual activity with a partner. So that is occupational exposure. That could also be a route of transmission. All right. Right. There's also what we call transfusion transmitted syphilis or transfusion acquired syphilis. All right. So what it also means is that if you can also get syphilis through blood transfusion. But the good thing is that all of us know that now routinely blood is screened for syphilis. Every blood, either the blood donor is screened or the donated blood, okay, is screened. So and because of that, because the blood, okay, so somebody wanted to know how the sore will appear on the nipple. Okay, so here we are going to look at we're going to look at the syphilis in stages, and in some stage we have what we call spirochetemia. You know that the organism, the bacteria, is a spirochete, and so once you have spirochetes in the blood, that will be spirochetemia. So at a certain time, the organism will move into the bloodstream, and once they're in the bloodstream, and if the person has a cut, a sore, on any sore, any open at all on the lips, what it means is that it increases the risk of you also contracting it. So it's not like a syphilitic sore. As we move along, we're going to look at syphilitic sores, a sore which is typical of syphilis. That one, we'll look at it. But on the breast issue, I'm talking about any opening, any cut, any sore at all. And especially in dry seasons, mothers, some of them could have cracks, great cracks or sores on their nipple, any sore at all on the nipple. If this individual, the person we are dealing with, that mother has syphilis which he doesn't know, then he's putting the life of the breastfeeding child at risk. So please, I'm not saying that we have syphilitic sore on the nipple. No, what I'm saying that any sore on the nipple will expose the child to risk of syphilis transmission. But as we move along, we're going to describe typical syphilitic sores, which is called chancre. Sometimes even described as hard chancre because the sore is really, really hard and painless. All right, so you get to know all these things as we move along. Okay, thank you too. All right, so we are having, so remember you talked about the mother to child transmission. I'm saying that has been reduced significantly. In fact, it's becoming rare. Mother to child transmission of syphilis, or for that matter, congenital syphilis, is becoming rare because mothers, especially unless you don't go to any clinic, but even if you go to a village clinic for antenatal, you'll be screened for syphilis. Okay, and that screening is rather helping to treat mothers who will otherwise have transmitted their syphilis to their unborn babies. So you see why mother to child transmission of syphilis has now become very rare. Similarly, transfusion transmitted syphilis is also rare now because donors are screened for syphilis. Every donor is screened. Even if the donor is not directly screened, the donated blood will be screened. So sometimes you go for blood donation campaigns, and if the numbers are too much, you may not have the opportunity to screen them before they donate. So all we do is that everybody should donate. But if after that donation, when you come back to the lab, you have to screen all donated blood. So here we're talking about screening blood donors or donated blood. I hope that point is also clear. So once you screen the donor or the donated blood, you are going to exclude all syphilis positive samples of blood, and then therefore they are not going to be transfused. All right. Similarly, not even similar, again, refrigerated blood. You know, the spirochetes. Just as we said, our sperms cannot stand acidic environment for even 10 minutes. Same way, spirochetes cannot stand the conditions in the refrigerator for more than 48 hours. Okay, so if the blood is, and most blood will be put in the fridge for some time before they actually get transfused. But of course, you can have situations where, especially in the villages where they don't, so rural areas where they don't have the benefit of a blood bank, they will donate the blood and then straight away to the recipient. So that's also possible. But here we are still hoping and believing that every blood before transfusion will have been screened, either screening the donor or screening the donated blood. And so that is how come transfusion transmitted syphilis is also now very rare. I'm putting all this out as scientists because you should know that, yes, these are all other possible routes of transmission. They are rare, and you should be able to explain why they are rare. And even the sexually transmitted one could be rare if everybody want to use condom. If everybody is going to use condom, then the possibility of transmission is also going to be rare. But of course, the young guys, masa condom na I want to do. Just a masa condom the on use. So that's why we still could have a sexually transmitted infection of syphilis. Otherwise, you see that all the possible routes of transmission are now being put in check, and that could also reduce the risk of the transmission. But that doesn't mean that you shouldn't know. You should know. All right, right. At least you know that there's something called transfusion transmitted syphilis or transfusion acquired syphilis, and you should know what it is. Right. Now, as scientists, you should know that syphilis cannot be spread through casual contact with objects. Hello, do you want to ask a question?
Yes, Kingsley, I want to ask a question
Yes,
here.
please. Yes, please.
Yeah, okay. My question has to do with the temperatures of the syphilis. I was reading something about transfusion medicine,
Okay.
and we came across fridge treatment.
Okay.
At that time, now I think CAT has also released some article about fridge treatment for syphilis.
Yes, sir.
And after donation, we had some blood components that they tested positive for
Okay.
the syphilis script that we use. So we were thinking, say, because of such article, we can the period of 2 weeks refrigeration of blood can inactivate the syphilis bacteria.
Okay.
But then we are advised not to take chances since it has tested positive.
Yeah.
We shouldn't go for the transfusion. I
Okay.
wanted to read about it. I was not finding any reliable source about fridge treatment of syphilis when it comes to transfusion
All right,
medicine.
all right, all right. Thank you very much. So there's nothing like fridge treatment. You see, we don't. You see, the thing is that all that we were saying is that if blood is put in the fridge for some time, if that blood is infected by treponins, treponins will not survive fridge conditions for even more than 48 hours. Okay, so but that doesn't mean that you are intentionally collecting syphilis infected sample, putting it in the fridge for about 2 weeks, and then giving it to. I mean that I don't know, but probably it was some research somebody wanted to do, but that would be unethical.
Yeah.
That would be unethical. Okay, right. All that you are saying, I'm saying here is that transfusion transmitted syphilis is coming down or getting low because of the screening that we do. And also the likelihood of blood being refrigerated for some time before the transmission. So all those things will reduce the risk of the transmission through transfusion. Is that point clear?
Yes, sir.
But so syphilis cannot be spread through casual contact with objects that an infected person has touched. Okay, so as scientists, you know this. So I remember I said that sometimes if you touch the infected person, the lesions on the infected, and we are going to talk about all those things. Sometimes there are some physical lesions on the body, in the palms and so forth. That one, if you touch that one directly, and you two happen to have, let's say, some cut or some opening in this thing, that one you can have it. But not that, oh, the person has a syphilis, he touches a door. And so if you also touch that door, or if you go to the washroom, and then you also go to the washroom, and if you also go, all those things, I mean, there is no scientific basis. So syphilis cannot be spread through casual contact with objects that an infected person has touched. I hope that point is clear. Like sharing utensils or clothing with an infected person, you won't get it. Using the same toilet seats with an infected person, you won't get it. So those things you should be clear. All right, so that nobody confuses you. Okay. All right. So then let's move on to the syphilis, the disease. It is a multi-stage disease. That is multi-stage, anything more than 2, even anything more than 1 can be said to be multiple. All right. So it is a multi-stage disease, and these stages are 4. So It's a multi-stage disease characterized by 4 distinct stages. Okay, and each stage has distinct or different symptoms. And as we move along, I'm not going to dwell so much on the stage by stage, but I'll do the first 2 stages, and then so that we don't waste too much time. But that is what is actually what you're doing. So the first stage is called a primary stage, also called a primary syphilis. It's characterized by sores, sore or ulcers. Okay. The next stage, or the second stage, of course, the secondary stage, is also characterized by rash and flu-like symptoms. You can even forget about the flu-like symptoms because as for flu, a lot of conditions give you flu. So, but there are some typical rash. Okay. And then there's a test stage you call latent. Latent means hidden. Okay. So once it's hidden, it means that there's no symptoms. But no symptoms doesn't mean that the infection is gone. So that is that. And then you can have the tertiary. Tertiary, where the disease now have been with the person, moved through first stage, second stage, third stage to the last stage, which is the tertiary. And now it will be targeting or affecting organs, including even the CNS, central nervous system. So once it affects the central nervous system, then you could have what we call neurosyphilis. Okay, so we are not going to do so much on those things, but you must know that. But the important thing is that you can move from one stage to another only when there has not been any treatment. But if at the first stage, the condition has been diagnosed and there's treatment, it will never move on to the second stage. Okay, or even if at the second stage, and then the infection is diagnosed and well treated, it will not move to the next stage. So that is what I want you to know, that the stages can only move on from stage 1 to stage 2 to stage 3 to stage 4 only in untreated patients. Is that point clear? That must be clear, that so that you don't say that, oh, once you are able to get to the 4th stage, means that there was no diagnosis or no treatment right from primary stage out to the last stage. Okay, right. So, but you see, syphilis is most contagious or infectious during the primary stage, secondary stage, and early part of the latent stage. So that even in the latent stage, if you are to do syphilis holistically, then you can also look at the latent stage. You can have early latent, you can have late latent, and you can have raw latent. They all mean a lot, but you're not going to do all those things. All that we can say is that, so for example, once the disease gets to the tertiary stage, they are no more infectious. Yes, you could have destroyed a lot of organs, stuff like that, but still the patient is not infectious. Okay, you cannot transmit or pass the infection to another person. That's what we mean by the infectivity. Okay, all right. So the early part, especially primary stage, highly infectious. And then secondary stage 2 is also infectious, and I'll tell you why. And then the early latent stage is also infectious. Otherwise, the last stage is non-infectious. All right. Please, as I've said over and over again, if there's a question, you can just stop me at any time, and then let's deal with it.
Hello, Grandpa.
Yes, sir.
Good evening, please. I'm Elga here.
Yes, sir.
My question about the infectivity at the stage is that I presume that maybe the bacteria moving from the primary stage to the tertiary stage untreated means that maybe the concentration of the organism in the patient's system would have increased. So why is it then that at the tertiary stage, rather, the person becomes non-infectious?
Okay. All right.
Thank you.
Yeah, okay. But you see,
okay,
like I said, the syphilis is a whole course on its own. And
okay,
I'm just touching on the surfaces so that we don't, but like you said, once it moves to the tertiary stage, okay, it targets it becomes like part of what do you call it? Internal organs. They are targeted internal organs. And I wonder how, if let's say the CNS or it can even attack the heart. It can attack even the bones. So how are you, and it's by contact. How are you going to get contact with the bones? How are you going to get contact with the CNS as itself? You understand? So the possibility of contact with the affected organs makes it almost impossible. Okay. For her. All right. Thank you.
Okay, thank you.
So we're going to do a little on the first stage, which is the primary syphilis. So primary syphilis is the time that you have been exposed to the infection. All right. When you have had contact either through sex or through whatever means with an infected person, then the organism will have gotten into you, and normally the point of contact, that is where you are going to get the organism penetrating, and that is where they are going to start their reactions or their infection, so to speak. And we are not going to go too much, as I've said. The certain is that, not the certain, immune system, the organisms develop in such a way that immune system is unable to attack them. You know that most times, if you get an infection, the innate organisms, so the innate immune systems are able to pick them up. Otherwise, all of us will have died by now. But a lot of the time, the infectious agents, as they go in, they are recognized by the innate distance, and then you're unable to cause an infection. But the toponyms are able to dodge the immune system. Okay. And so even if it's one organism which is going to go inside, that organism is going to be allowed to stay there and then multiply and cause the disease. Okay. So the primary syphilis often appears about 3 weeks after exposure. That's when you have been exposed. Incubation period is about blah, blah, blah. So once you have been exposed, then the organisms where they penetrated, they will begin to also multiply there. And then that's where you get a swelling, and that swelling will burst or split to create a sore. That's all. All right. And it is this sore which is very, very characteristic. Okay. It's either a single sore, which is called solitary, or could be multiple. All right. And I'll show you a slide about the multiple sore. And like I said, these ones, you're looking at the penis. So you're looking at a sore on the penis. All right. The sore is usually firm. It's like you can hold the firm. No, sorry, I say you can hold the firm. You can hold the sore and know that it's like a firm lesion. Okay. They're usually round and smooth and hard. These are the characteristics of the syphilitic sores. And importantly, as I've underlined here, they are painless. These are called chancres. The sore, this characteristic sore is called chancres. And the next time when we are dealing with the chancroid, the difference between chancre and chancroid, you know this medical terminologies. When you have the suffix OID as a suffix to a word, what does it mean? If you have the suffix OID to a word, medical terminologies. So OID to a word is just, it's like, just as we have ulcerative like, listen. Okay, so if you have OID like, you can have, when you say amoeboid, you know an amoeba. All of you know an amoeba and how it moves. So when you say it is amoeboid, what does it mean?
It looks like amoeba.
Yeah, but it's not amoeba. It looks like amoeba. So when we have the OID as a suffix, medical terminology, these are some of the things that should guide you. It means it is like it. So this is chancre. Chancre is this typical source that will appear on your penis. And when you have chancroid, you're only removing the S here and adding OID. So it becomes chancroid. So it is like a chancre. Chancre is typically the ulcer which appears when you have syphilis. Chancroid is also like a syphilis. The only difference here is that the chancre, the typical chancre, which is a sore on the penis or the genital area, is hard. Okay, it's hard. You can touch it. The person will not even feel it. But with the other one, chancroid, which is called by Haemophilus ducreyi, it is soft and very, very painful. So if somebody has an ulcer on the penis, if you want to touch it, and you see that when something is very painful, the person will not even allow you to touch it. The thing is so painful. Even as you push, you go close to the sore, the person will just be pushing backwards. He will not allow you to touch it. That's typical of chancroid. So the original one is the chancre, which is the syphilis-associated sore, and they are hard. So sometimes we use the adjective hard chancres. So if you talk about soft chancres, then soft chancres will be the chancroid, which is caused by Haemophilus ducreyi. So even physically, as a scientist, this one straight away, if somebody comes to you with a sore on the penis, sometimes the doctors, as soon as there's a sore on the penis, straight away they think that it is syphilis. That they come to you in the lab, and if you attempt to take a swab, if in taking a swab, the person just allows you, can just allow you to wipe the surface of the listen without even saying a J, then you know that it is syphilis, because that one is painless and the person can allow you to do anything with it. But if it's so painful, said that the person will not even allow you to touch the penis, let alone swab it, then that is unlikely to be chancre, and for that matter, syphilis. So that could be chancroid. And that one is caused by Haemophilus ducreyi. All right. So these are the very first things as a scientist. Physically, you should be able to associate with syphilis. All right. So the presence of hard chancres, so the hard in quotes, signifies the primary manifestation of syphilis. So that would be the primary stage. All right. But as we move along, you see that, okay, so this is a picture of, so you see this is multiple chancres. This is about 3 of them. Okay. And this 2 large chancres. Okay. So this is a typical syphilis. All right. The thing is that this one may have developed within 2 weeks or 3 weeks. Okay, 3 weeks, you could see that. So how do you, so physically you think that is syphilis, but you want a laboratory diagnosis. All right, so how do you make the diagnosis? All right, so you move to that, the diagnosis side, and you see the way to diagnose it. So still the primary syphilis, without treatment, the lesion, which is the sore or chancre, spontaneously disappear within 2 to 6 weeks. So almost always without scar formation. So these ones can go away, no treatment, nothing. They'll go away. And you can have the feeling that, oh, that meanwhile, this one will not pain you, don't do anything to you, and then but unfortunately, if you are dealing with males, if this thing happens in the female, and let's say it happens in the vaginal area, he may not even see it. The woman may not even see it. And then even once he's bathing and washing this place, even if he's washing the place, I mean, nothing, it's painless. So you will not even feel anything that, oh, I think there's something in my vagina area or even in the vulva. You will not feel anything. Okay, so you will just be living with it for only God knows when. But for men, you are unlikely to miss it. The only thing is that probably within 2 weeks, 3 weeks, that it will appear spontaneously without treatment, and you may get the impression that the thing is gone, and you may just let it go. Like the disappearance of the chancres do not signal an end to the infection. That's very, very important. The lesion in the primary stage typically contain large numbers of spirochetes, the treponins, that make them very contagious or extremely infectious. Infected persons in this stage can easily pass the infection to their sex partners. So these lesions are teeming with treponins, which you can, of course, can't see with your naked eye. So it means that if you swab, if you take an exudate, you know an exudate, if you take an exudate from these lesions, they have a lot of the treponins. Okay, that's how come they are very, very infectious. All right, good. So saying the untreated, so that's the primary stage, and the manifestations are there. Source, typically that will tell you that the patient has. But unfortunately, as you move to you move to what we call syphilis serology, or the immunology of syphilis. And for all you know is that in all cases, immunologically, and what people call the window period, if you have an infection, it will take time for the immune system to respond or for antibodies to be produced. And so within that period that you have the syphilis, if you go and do a test, serologically, it will show negative. This one is simple. So the doctor, but this soil is syphilis power. He goes to the lab and then comes and tells you, oh, the test is negative. All right. Meanwhile, the serological test you go is dependent on determination or detection of antibodies. Antibodies will not be produced overnight. All right. And so that is where the problem comes. And so that you do a test and say it's negative. And so the patient too, within some few weeks, the sores to go away. Meanwhile, the lab says the test is negative. So the patient will go away. All right. And if you don't take care, there's no treatment. And then, so it moves to the next stage. So in untreated primary syphilitic patients, the treponemin gain access to the bloodstream. I hope that point is clear, because we said that
See, you want me to let you check. So you are disturbing me. You do want me to know.
Gladys, Ale, will be your wage man. The way you are mourning is like something is happening to you.
Grandpa, please don't raise my son. Sorry.
Yo. All right. But I hope you are listening.
Yes, please, Grandpa.
All
I'm
right.
listening.
So you're saying that the lesions, and for that matter, the source, the primary source, they are teeming with spirochetes. And we are saying that they will go away spontaneously. The spirochetes will get access into the bloodstream. All right. Meanwhile, the patient has not been treated. It's not been diagnosed. It's not been treated. And so the treponins gain access to the bloodstream. And we have what we call hematogenous spread. It means that it's spreading within the blood. And a spread of treponins in the blood is what we call spirochetemia. Remember, we said that when you have the EMIA, it's blood, septicemia, bacteremia, parasitemia, and then, of course, here we're talking about spirochetemia. So we are talking about spirochetes in the bloodstream. All right. So that one will be responsible for the signs and symptoms of the secondary syphilis. So the spirochetemia will now trigger the secondary conditions. Okay. Now, the secondary syphilis typically begins about 2 to 6 months after the primary syphilis lesions. Okay, so after the primary lesions or sores heal or goes away, by that time, the bacteria, for that matter, the treponins, have moved into the bloodstream, and then they are also coming back in another form. What they manifest is rather mucocutaneous, non-itchy rash. Okay, right. And non-itchy, you see rashes which appear reddish brown spots, and they don't itch. So, and they appear on the trunk. When I say trunk, like the body, and then including the palms and soles of the feet. And these are typical of secondary syphilis. So syphilis rash that appear as reddish brown spots that can appear on the trunk, that's the body, on the palms, and then on the soles of the feet. So these are all typical. And this one, these lesions, this is what I'm talking about. These lesions also contain the organisms. And for that matter, if you touch the person physically, I mean, with your bare hands, and if you also, especially if you hug or you do something like that, and then, meanwhile, the thing is not itching the person. And you too, probably you don't want to embarrass the person, and then you hug. And if you also happen to have some, especially if you happen to have some cut of a sort on the body, of course, then you can get yourself infected. All right. So that is also the secondary syphilis. So you not move to the latent and then the tertiary. All right. But at least you've gotten some idea about the stages of the infection. So we'll come to diagnosis. And in diagnosis, you look at the primary syphilis. We are saying that in the primary syphilis, one, antibodies have not been produced. Okay. So your best bet is to do a microscopy to detect the organisms. Is that right? So you want to detect the bacteria, for that matter, the organisms. Meanwhile, we told you that the conventional microscope. Okay, so let's get this point. So the diagnostic limitations. The limitations here is that conventional microscopy, that's the normal microscopy of gram stain, is insufficient to visualize the T pallidum because of the bacterium's poor uptake of aniline dyes. What it means is that if you want to do gram stain, the organism will not pick the stains, and therefore you wouldn't know whether they are gram positive or gram negative. And even if they were assuming that even if you're able to gram it, your normal microscope will not be able to pick it because you said that the organism is so slender. Okay, so slender. Remember, we said that the length is about 5 to 20 microns, but the diameter is just about 0.1. And if it's 0.1, it makes it so slender, so thin, to the extent that microscope, the normal microscope that you're using have a resolving power of 0.2. So how can it observe something in the range of 0.1? It can't do it. So it makes it cannot be observed using the normal bright field microscope. So that's the challenge there. One, it cannot be stained by gram stain because the organisms don't pick the stains. Two, even if it were stained, the normal microscope that we're using cannot visualize the organism because it is sub-microscopic. When I say sub-microscopic, that is below the level of the microscopy, and so it cannot be seen. Then let's say, okay, if you can see, can you culture it? The organism is not culturable. You can't culture it in a routine lab. Of course, there are some specialized labs where you are trying to put it into rabbits, and that's a special means of culturing where now the organism can be cultured using rabbits and blah blah. So in routine cultures you can't do it. So it is not questionable. So the organ, you can't stain it, you can't examine microscopically, you can't culture it. So it means that it gives a lot of limitations in the diagnosis of primary syphilis. Now, so is there no way? There is a way. Let's look at the way to go. One, we are saying that the chancre of the primary syphilis contain large numbers of spirochetes. That one has been established. So you see that the source, the sore or the chancres, they have large numbers or teeming numbers of the organisms. Okay. So testing for syphilis is based on the detection or direct observation of T. pallidum organism by dark field microscopy of the lesions or exudates. All that we're saying here is that now you are aware that the primary lesions have a lot of organisms and they cannot be examined under the current or under the routine microscopy, but they can be observed under dark field microscopy. Okay, unfortunately, most labs don't have dark field microscopes. Elsewhere, you have dark field microscope, you have fluorescent microscopes, and so forth and so on. So those ones are able to observe. Here, you are going to observe the motility of the organism. Okay. So once you know that the lesion has a lot of the organisms, you swab the area, you scrape the area, can even scrape because the thing is painless. The patient can allow you even to scrape on top of this thing. And you take what you call the exudate or any fluid that is coming. Those fluids exudate contain a lot of organisms. So just examine it under dark field and you see the corkscrew motility of the organisms, and that is all. So it means that becomes your source of identification. So your testing method in the primary stage is to collect and process the specimen. The surface of the lesion, which is the chancre, is cleaned with saline and generally abraded. When it's abrading, I hope it's like you are scraping on top with dry sterile gauze. Bleeding should not be induced, okay? Because if you induce bleeding, you are also now likely to cause some of the organisms to move into the bloodstream straight away and then start the second stage or the secondary syphilis immediately. All right. So the abraded material or serous transudate, that is the fluid that we get from the lesions, just placed on a slide, dilute with saline, because you may have scraped a lot of the thing. If you don't dilute with saline, it becomes too thick that you can't even examine. And cover slip is applied. Then the smear preparation is examined under a dark field microscope. That's all. And you see the movement. So the preparation should be examined immediately after collection while the treponemics maintain their mobility or motility. And that is your definitive diagnosis. So the diagnosis of primary syphilis is by dark field microscopy, simple. It's not by gram stain or by wet mount or by anything. It is by dark field microscopy, and that must be your take-home information. So definitive diagnosis of primary syphilis is based on the direct detection or visualization of the motile treponemes in material from the chancre or the lesion exudate in dark field microscopy examination. All right, this should be done before the production of antibodies in sufficient quantity for serological detection. And I'm hoping that the information on the slide here will complement the submissions that I've made already. Okay, and I hope that makes that is good to go. All right. So let's quickly take a look at what is called syphilis serology. Serologically, I mean, it's like here, serology, you're dealing with antibodies, okay? So syphilis serology. Following infection with the bacterium Treponema pallidum, the body develops two different classes of antibodies that should be established. Unlike where if you have infection with any organism, I mean, you produce antibodies, and one of the characteristics of antibodies is their specificity. They are specific against the agent that induced their production. So if you have an organism A, it will produce antibodies against the organism A, not organism B. Okay. Here, the treponema is producing two different types of antibodies. And this is where scientists must appreciate, understand well to guide their diagnosis and their testing, and of course, their interpretation of the results. And this, I'm saying that there are a lot of confusion going on in our labs. Okay, right. So there are two different classes of antibodies. One is called non-specific. The same, because the non-specific, it is also non-treponema. What it means by non-treponema is that when the antibodies have been produced, then they can also react with, like I say, if you have an organism A producing an antibody A or anti-A, if you react it with organism B, the antibody A which has been produced cannot react with it. I hope that point is clear. But here we are looking at antibodies. If it is the treponemes that have produced the antibody, this antibodies is now able to react with, let's say, malaria, or react with if you know autoimmune antibodies. Some autoimmune is able to react with it. So it means that it is reacting with things other than the treponemes. So they become non-treponema. And because they are reacting with non-treponema antibodies, they are now also become non-specific. Okay, because when talking about specificity, we are saying that if it is against A, it's against A, not B. That's the specificity. So here, the class of antibodies that is producing, they are first and foremost non-treponema because they're able to also react with other things other than the treponemes. And that makes them non-specific. So they are non-specific non-treponema, and they can react with anything. These antibodies is called reagent, not reagent, reagent. Take note of this one because as we move along, we are going to look at rapid plasma reagent. And the reagent is coming from this point that we are making now. All right. So this kind of antibody, the ones that are non-specific, they are also non-treponema antibodies. That class of antibodies is called reagent. Okay, good. Then after that, they also produce specific antibodies, which are treponema. Okay, now the specific antibodies which are treponema are directed against antigens specific to T pallidum. So please, ladies and gentlemen, take note of this because it's causing a lot of confusion for our people. Now, I'm sure you understand the first point, the fact that they are non-specific, non-treponema, that they produce two kinds of antibodies. The first one, they are non-specific, non-treponema, so that they can react with anything. Okay, and they are called reagent. So you understand that one. Then again, they also produce another class of antibodies. These ones are specific. And so they are called treponema. But remember, they are specific to treponema pallidum. But remember, we said that even the T pallidum, you have T pallidum, subspecies pallidum, T pallidum, subspecies petini, T pallidum, subspecies endemicum, and then caryatum. So it means that even though here we are saying that they are specific, but they are only against the T pallidum. So what it means is that they cannot even also differentiate between yours, syphilis proper, Bigel, and then the Pinta, because that is also another subclass of the T pallidum. But at least they are telling us that these ones, the first one, non-treponema, they react even if somebody has malaria, even in normal pregnancy, you can have it, and we'll deal with all those things. We call them biological positive factors. Okay, we'll deal with those ones. So even if the the person is pregnant, the father is pregnant, you do the non-specific test, it can show positive. Okay. If somebody has malaria, you do the test, it can be positive. And then if the person also have treponema, of course, can also be positive. So it means that what are you talking about? It's like it's misleading everybody. So it makes it non-specific. But at least you need that one to tell you that, oh, it could be the toponyms or something else. And then from there, you can come back and do the specific one. Because the specific one, if for anything at all, to show you that this is T. pallidum. All right. So you need to get these fundamentals right. That the same syphilis itself, the troponin, once it gets into a human being, it develops two different classes of antibodies. The non-troponemal one and the troponemal one. The non-troponemal one is also called non-specific antibodies. Then the troponemal ones are also called specific antibodies. Okay, right. So the non-troponemal and non-specific tests typically have been used as, they normally have been used, the non-troponemal one, of course, they're the same thing as the non-specific tests. They have been used as screening tests for syphilis, screening. Okay, they are used for screening. However, they can also be used as diagnosis. When I say they are diagnosis, like confirmed. They can also be used, even though they are screening, they can also be used as diagnosis when patients have signs and symptoms suggestive of syphilis and have a known sexual contact. So the person, you do the non-troponemal one or the non-specific one, which is positive. You say that technically it's used for screening. All right. When we say something is for screening, it means that it is not diagnostic. It is not confirmed. However, the same test, which is non-specific and can be used as confirmation test if the patient actually have told you that, oh, I have a sexual contact with somebody who has been diagnosed of syphilis. So that one is there. And then the patient also have signs suggestive of syphilis, like if we assume that he's even in the second phase, where he has rashes all over, including the palms, and which is suggestive of syphilis in the secondary stage. And the patient have told you that, oh, I've had a contact with somebody there. So with that clinical information, the fact that the non-troponemal test is positive, you can use this as diagnostic. Does it make sense?
Yes, Grandpa.
Yes. So it is not, we are scientists, so I just want you to understand all these things, that yes, typically the non-specific test is for screening. And once it says that for screening, it is not confirmed. However, the same test, which we say it is non-specific, can be specific once it is supported by information such as a known sexual contact, and then also having clinical, especially if it's even in the primary stage. Remember, in the primary stage, we say that it can last for 6 weeks. And as we move along, you see that antibodies can begin to develop from a 3rd week going. So it means that at the latter stage of the primary stage, antibodies can be obtained. Is that true or false?
That's true.
That's true. So it is not true that within the whole primary stage, serology serological screening should be negative. It is not true. It depends on what stage of the primary stage you're talking about. If it's the early primary stage, of course, you don't expect antibodies to be present. But in the late primary stage, antibodies could have been produced. So it means that you can still have the antibodies produced. You are doing the test, which is non-troponemal, supported by the fact that the patient has what do you call it? Lesions. Okay. So the presence of the lesions alone, plus the fact that your screening test is showing positive, can be used as diagnostic or confirmation. All right. Now, the non-troponemal test to when assessing possible reinfection, patients who are known to show positive, who have been what do you call it? Yes, who have been diagnosed, okay, and then they have been treated. as we move along, you realize that the non-treponemal test, once the patient has been treated, over time, the distance will go away, the antibodies will go away, and the test will become negative. Okay, the test will become negative. Now the patient has become negative, and then all of a sudden you do it again, become positive. It means that there has been possible reinfection. So in that case, once the patient is a known case, and then he's becoming positive again, you can use it as a reinfection. Okay. Now again, the non-treponemal ones can also be used to monitor treatment outcome. Because as you move along, you realize that once the patient has been treated, we are talking about two classes of antibodies, the non-treponemal and the treponemal one. The non-treponemal one, after effective treatment, the this will go away. The antibodies, but they will not go away all of a sudden. What do you understand antibody titers? Do you know titers? Hello, ladies and gentlemen. Do you know antibody titers?
Yes, sir.
You know titers. That is like their concentration of a sort. Okay. I think somebody has even put something here a long time I didn't see. The stages are not classified based on the titer or load. You see, the titer is like the person is saying the load. So, and in this course,
that was when the one asked that stage 1 is infectious, but at the stage 4 it's not infectious. And he was thinking that as the disease progresses, then the virus become more active or the titer increases. And I was trying to say that the classification is not based on the titer.
All right. Okay. Thank you very much. Thank you very much. That's good. So you have fairly good idea on the topic. So the titer is like the load. So we're saying that if you have treatment, then if the treatment has been effective, the titer will begin to go down to the point that now the whole thing becomes negative. Okay. So you can use it to monitor, so that what it means is that once it's positive and you have been given treatment, you will take the person's titer. Okay. Now, after time, you also take the sample again and then check the titer. That's the load, the level of the concentration of the antibodies. When you talk about the load, then it's like you are talking about organisms. But here, you're talking about the antibody concentration. So let me use the word concentration. So you check the antibody concentration, and then over time, you check it again. If there has been a reduction, and we're going to talk about the titer, the dilutions. So if there has been a 4-fold reduction, then it tells you that the patient has responded very well to treatment. But if after time, you check the titer and it is still the same level, or there's not be any reduction in the titer, then it means that there's been a treatment failure. All right. So with the non-treponemal type, it can be used for so many things, not just for the screening. All right. So these are the 4 major things that can be used for the non-treponemal for monitoring the treatment. However, when it comes to the what do you call it? The confirmatory one, the treponemal one, it cannot be used for monitoring treatment. And I'll tell you why it cannot be used for monitoring treatment. So, but with the non-treponemal, even though it has challenges, it has limitations, but the benefit is that it can be used to monitor treatment, because it can be, you can use it to check the titers, the levels of the antibody levels, which is called a titer. Now, for the non-treponemal, or the basic test, you use VDRL and RPR methods. The VDRL, you know, Venereal Disease Research Laboratory. It is named after the laboratory that actually produced the test. And then the RPR is rapid plasma reagent. Remember, I told you that the non-treponema antibodies are called reagent because some scientists think that it's not antibodies. If they were antibodies, they'll be specific because one of the key characteristics of antibodies is their specificity. Antibody will react with the antigen that induces its production. You're going to have an antibody that's reacting with a different object. But with this one, the antibodies will be reacting with other things. And so they think that it's not a true antigen. And the name reagent, the terminology reagent was developed. So you're going to look at it and then the VDRL. So the original test is the VDRL. And this RPR is a modification of the VDRL. As we move along, you see the differences. RPR is a modification of the VDRL. So it's the same test, and they are all used as non-treponema tests, which can be useful for screening, diagnostic, assessing possible reinfections, and for monitoring. Good. So the treponema tests themselves target specific T pallidum antigens. Okay. Treponema antibodies generally persist after treatment and cannot be used to distinguish between current infection and previously treated infection. This is where the catchword is. Remember, I said that with the non-treponema one, let me go back. When we have an infection with treponemes, they will trigger the production of two classes of antibodies. One is non-treponema, one is treponema. Okay. The non-treponema one, the levels will begin to reduce upon treatment. So the treponema antibodies, or the non-treponema antibodies, the levels will begin to go down when patients have been effectively treated. And with time, the titers will go down, and become negative. Okay. So that is the good thing about the non-treponema one. With the treponema one, once you have been exposed, the antibodies will persist throughout your lifetime. Okay, the antibodies for the treponema antibodies will persist throughout your life, not after some time, unlike the non-treponema one. And we say that the non-treponema one, the test methods are RPR and VDRL. We say that the original test is VDRL. Okay, the original test is VDRL. And the VDRL has been modified, and you see why the modification. Why are they not maintain the VDRL, but they are being converted to RPR? Of course, you will see the difference in the next slide. So whether it's RPR or VDRL is the same thing. Now, that one will check the non-treponema antibodies. And once the patient has been treated, especially once the treatment has been effective, with time, if you do the VDRL or the RPR, the test should become negative. Even if it hasn't become negative, you can check your titers. As the titers reduces, that alone will give you the assurance that the treatment has been good. However, when it comes to the treponema ones, the antibodies will persist throughout your lifetime. And so there's no need to check any titers. Okay, you don't need to check it because it will be meaningless. It will be useless. Okay. Now, the problem or the challenge we have in Ghana, in most labs, is that everybody is using the strip. And the strip, even before we get there, because we'll be closing very soon. Now, I want you to get this point before we close today. The strip, the VDR, so-called VDR strip, is based on immunochromatogenic or immunochromatographic technique. I know that immunochromatography is based on, it's like ELISA technique, and it's very specific. Once it's specific, is it treponema test or non-treponema test? if you are using a method which is based on immunochromatography, which is like an ELISA, will you consider this test to be treponema or non-treponema? I'm getting an answer from you.
Non-treponema.
Come again. Oh, you said, eh? I'm saying that the VDRS, so the so-called I've said so-called VDRS test strips that we are using almost in every laboratory in Ghana is based on immunochromatography. Immunochromatography is in the same line as ELISA. And you know that ELISAs and immunochromatographies are specific. Is that it? So once they are specific, they will be specific for T pallidum. Now, if you look at it, the VDRS strip, are they treponema or non-treponema tests? Hello? The strips you are using, are they treponema or non-treponema tests? Come again.
I think it will be treponema test.
They are treponema tests. And so we are saying here that treponema tests are specific. Okay. Because they are based on immunochromatography. They are specific. Once they are specific, they are treponema tests. And here we are saying that treponema tests or treponema antibodies will persist throughout the person's life. So you see that somebody could have syphilis. He may have been treated. He comes to your lab, and then the doctor have written VDRL, and the lab decides to use the strip. Meanwhile, we are saying that VDRL is based on non-treponema. Okay, it's a non-treponema test. Meanwhile, when the clinician requests for VDRL, you are using a strip. Is a strip non-treponema? Strip is non-treponema. So if you have the request has come to you as VDRL, and you decide to use a strip, what do you think you are doing? You are not doing what the doctor has asked you to do. The doctor wants a VDRL test. A VDRL is a screening test. All right. Meanwhile, you didn't do that one. You are using a strip. The strip is treponema. And so that's how come somebody will come to you. They will do the test. It is positive because the person used the strip. And so the test will be positive for treponema. Remember here, the second point here is saying that treponema antibodies generally persist after treatment. And indeed, I want to add that they will persist throughout your lifetime. So the person will come to you, the doctor will treat him, because the lab says positive. The patient will be treated. After 2 months or 3 months, we come to you, or you go to another lab, then the test will be positive because the other lab is also using the strip. The strip is based on the treponema procedure, treponema test. So the test will show positive. So throughout the person's life, you will show positive, and if you don't take care, then the doctor will move from one doctor to a doctor, and they will move from one lab to another, and every lab is using the strip. And the treponema test will never be negative once the patient has been exposed. So we are doing a lot of harm to our patients. And this one, even though we will do the proper interpretation, but just to end here, what we are doing in our labs is not VDRL. What we are doing in our labs is to do treponema tests using the strip. Or if you go to your lab, you check on the information on your VDRL, so-called VDRL strip. They are testing for TP, which is treponema pallidum. Treponema pallidum, they are specific.
Grandpa.
Once they are specific. Yes, sir.
So if the request comes that VDRL, please, what test should we do? What should we?
Good. So by the time we finish this thing, we will go through. You see, there's what you call, what is an algorithm? In the lab, what is algorithm?
That's a stages or guideline to follow when during
Fantastic.
testing, like one after the other.
The stages or guidelines to follow for a test procedure. So if you have a confirmatory test and a non-confirmatory test, a screening test and a confirmatory test, which one will you do first?
You first do screening before you confirm.
Very good. You first do a screening. If the screening is positive, then you go and do what?
Confirmatory one.
Confirmatory test. That's the normal thing. Remember when we were talking about the ejaculation, we talked about the antegrade and the retrograde. The antegrade is the forward flow or the normal thing, the normal flow. Okay. So the normal algorithm is that in all circumstances, you do your screening one first. If your screening test shows positive, you go ahead and do your what? Confirmation. However, you also have what we call reverse algorithm. Just as we have the antegrade and the retrograde, we have reverse algorithm. In the reverse algorithm, you are allowed to do the confirmatory test first. Okay. If the confirmatory test shows negative, go ahead and report as negative. Okay. But if the confirmatory test, as far as syphilis is concerned, if the confirmatory test is positive, go back and do your screening. And that's what we call reverse algorithm. Have you heard it before? Have you heard the principle of reverse algorithm before? Any one of you?
It has passed through my mind in HIV screening.
Okay. So
the use of first response and oral quick and those
so
stuff.
that's reverse algorithm. So we have the normal, that we have the algorithm, that's the normal flow. The normal flow is that you do your screening first. If the screening is positive, you go ahead and then do your confirmation. If the screening is negative, you don't go and do your confirmation. So that's the normal thing. So you call that one the normal algorithm. However, if you decide to do the confirmation test first, if the confirmation is negative, go ahead and say that it's negative. The whole thing is negative. However, if the confirmation, as far as syphilis is concerned, if the confirmation says positive, you go back and do the VDRL. Why? Because the confirmation test is based on what? The treponema antibodies. And the treponema antibodies will persist throughout your lifetime. So if the patient has had infection and has been treated, if you do the treponema test, will it be positive or negative?
It will still be positive.
It will be positive. Meanwhile, because he has been treated, what do you think will happen to the non-treponema test?
That one can be negative for the title.
Negative. So you do the treponema one first. It is positive. If you go ahead and report it as positive, the doctor will still give treatment. But if you go back and do the VDRL, if the VDRL is negative, it tells you that this is a past infection or previously treated infection. And this is what the lab is not doing. And they are allowing patients to be subjected to all kinds of treatment for somebody has been treating syphilis throughout his or her lifetime. And that is the cause of the lab, because we appear not to understand the science behind what we are doing. You see, I remember I've intentionally not talked about the discussion that's going on the GAMS clinical voice platform. I made a presentation on this at Congress, because I realized that, you see, when a doctor will write VDRL, okay, and then it goes to a lab and then they use the strip. The strip is positive. Then the lab will report VDRL positive, okay, or reactive. Based on the fact that the VDRL has been reported as positive or reactive, the doctor will now think that the doctor knows that VDRL is a screening test. So the doctor will now write TPHA. The TPHA is actually another treponema test procedure, which people are not using anymore because the strip is faster. So the doctor will now request for TPHA. He goes to a lab, and then the lab people will still use the strip to test for the TPHA. And then they write another positive. You see, I ask myself whether I don't know, but let's end here. So this is what is happening. As we move along, by the time you finish the whole program, you understand better. But what I'm saying here is that the take home for this evening is that if you have a strip, if you have a strip in your lab, go back and read what it is. What is the technology used? It is immunochromatography. Immunochromatography is specific for TP. Once it's specific for TP, it means it's a treponemal test. Once it's a treponemal test, it is detecting treponemal antibodies. And once you know treponemal antibodies don't go away after treatment, they don't go away. They will persist with the individual throughout the person's lifetime. And therefore, if you do a test, usually using the strip, the patient will never turn negative. And once he takes it to the doctor, you say, lab, then the injection, so then you will be subjected to no co-treatment, you will move to another lab. All kind of things is going on. I hope that then the question is, so how will we do the VDRL? Okay, so let's even though it's time, but I think we'll tackle that tomorrow, God will. I'm saying that we are going to have another one tomorrow. And if you all agree, can we meet tomorrow or we make it next week? Are you available for tomorrow or
let's meet tomorrow.
Grandpa,
Yes.
next week?
Yeah. Tomorrow.
Next week or
Tomorrow.
tomorrow? I'm hearing next week, I'm hearing tomorrow.
Tomorrow.
All right.
Tomorrow.
So tomorrow we start, we'll continue, and then we deal with the VDR and RPR concept. And I've already
Grandpa, please, what time?
Oh, same time tomorrow, please. 7 to 9. All right.
Okay.
Thank you very much. Good night and see you. But the fact is that we are doing a lot of the service to our clients. And let's start to see how best we can make the change. All right.
All right. Thank you so much. Thank you.
Yeah, welcome, sir.
All right.
Where did you get it?
I saw it there at the time. Go.